Okay, so a bit of an overview on what the solution, what our functionality in the solution does. So it's designed to be used by one or more screening programs.
Okay.
Right.
So in our case, the cervical mammography and colon.
Correct.
Okay.
Yeah. So there's one, we'll see it through the demo, but there's one client record in CRM, but there's 3 program records. Each client could have up to 3 program records.
Okay. Only 3, or there could be even more?
It could be more than that.
Right.
But for the purposes of the cancer agency, it was 3
Right.
programs so that each patient could have up to 3
Right. Okay.
program records. Okay. It interfaces through the use of that data warehouse with legacy and current information. So basically, when we look at the diagram, the warehouse takes the data that's required from the clinical information system,
Yes.
processes it, puts it into formats that we can then add it to CRM.
Oh, okay. So the data that we're grabbing and putting into CRM, we're not going in and have a view into the entire data of the clinical. We've been given a filtered view already, so there's no sensitive information that we're not allowed to have.
First, one of our main design principles was that we could not have clinical information. There could be no way for CRM to access clinical information.
Okay.
Because it just didn't meet the security requirements
Right.
of the ministry.
Okay. Okay.
Plus, then it eliminates all sorts of like almost unnecessary requirements for system security and audit requirements for recruitment and retention purposes.
Okay.
The information doesn't need to be there. Supports importing and processing large sets of external data from external sources. So the Ministry of Health provides a list of all women who are 50 that are living in BC to the program. So then they can go through and identify whether they are eligible for screening, which means if they've been screened before, they're not going to invite them.
Okay.
If they are on the cancer registry for having had breast cancer, then
Okay.
they check vital stats to make sure that the person is still alive.
What's the role or title of the person within the provincial ministry, within provincial health, sorry, not provincial ministry, within PHSA in the screening program that would be looking at that and determining that information to send these?
So the programs come up with rules about what are the eligibility rules for each program.
Okay.
And what they want is when this data is received,
Okay.
when the big file is received,
Yes.
then pare down that file to give CRM a list of all the people that are eligible for screening that we can recruit.
Okay. It does.
So the program directors, the program managers come up with the criteria for screening eligibility. And they've already figured out what the target population is. So the data file coming in is only includes people that fit.
Is already filtered to that subset.
Yes, exactly.
Right,
and then they pare it down even more with the information that they have within the cancer agency and within the health authority.
Okay, gotcha.
Okay, so client record management for recruitment and recall. So there's a single client registry, like we just talked about, in the system that consolidates the client's data from all these other sources. So we just have one record to deal with.
Yes.
And then recruitment and campaign management. So this is the most complex module of the system, is the recruitment piece of it, and where we've customized it the most. So currently, express screening of recruitment is done once a year. And they target women in BC that are turning 50, because this is the beginning of that high-risk population, right at 50. So 50, if you haven't been screened prior to that, this is when they're going to invite you to be screened for the first time.
Okay.
And notify you of the services, whatever. So doing this once a year, it means that they are inviting like 17 to 1,800 people, I think.
Well, that's it. I almost would have assumed more.
1,000, maybe.
17,000.
I can look at the numbers for you. Anyways, so they get this data file, right? So once they come back with their list of who's eligible for and who we need to recruit, then they want to process that, like send it out over a period of time. If they sent it all in 1 week, the call center would be inundated and the screening centers would be inundated. They can't handle that volume.
Oh,
so they have a whole bunch of...
So there's a lot of planning around staggering.
Tons of planning, yeah.
Okay.
So they'll take that file and they'll mail it out over, say, an 8-week period.
Yes.
And because they're dealing with the whole province, they also want it to be dispersed across evenly over the 8 weeks over all the different
across
areas.
geographic areas? And,
Yes, exactly.
Okay.
So that's also type of processing that we built in.
Right. Oh, interesting.
So there's also some complexity around that. And then it produces letters or large files. So depending on whether the screening program's printing and mailing the letter, or whether they have an external company doing it.
Okay.
So it produces individual letters if they're sending it out. That's what they're doing for colon check right now, because they're only dealing with 2 geographic areas. Or it'll produce a big data file of names and addresses.
Okay.
Okay, so we added a lot of automation around their processes for both recruitment and recall. So based on their policies and their parameters that they enter in CRM, the letters are automatically generated on a weekly basis, on a monthly basis, whatever is required.
Oh, okay.
So they just have to do this setup once, and then receive the file when it's spit out, and send it off for distribution.
Okay.
It supports client opt-out and tracking in eligibility processes through the use of workflows. So if a person receives a letter and they say, I don't want to participate in screening, then they can flag that in the system and they'll never receive a letter again.
Okay.
If the person doesn't meet all the eligibility criteria, then that's also flagged so that they don't have to continue to go through that eligibility check every time they receive a data file.
What's an example of not meeting eligibility?
You're on the cancer registry list for having been diagnosed with breast cancer in the past.
Okay.
If you've ever had breast cancer, you from that point on always remain in the diagnostic stream.
Oh,
you never
okay.
go into
Right.
screening.
That makes sense.
They're monitoring them more closely, and
okay.
It's different.
Yes.
If you have breast implants, you are not eligible for screening. You have to go through diagnostic.
Okay. Trying hard not to laugh.
Yeah, I know. Okay, so we've got extensive security and user auditing functionality in the system to meet the Ministry of Health requirements.
Okay.
Okay. It requires the use of SQL Server 2008. And then the data files that are sent out for third-party distribution have a 32-bit data encryption.
Okay. So it's sent out to third-party distribution. Maybe you could explain that a little. Why don't they print the letters and lick the stamps themselves?
So from mammography or breast screening alone, each week they send out a file of women that need to be recalled for screening. So they've been last year, they've been 2 years ago, and they need to come back.
Okay.
That file every week is 700 to 800 people.
So a lot of people.
So it's printing off 700 to 800 letters.
Right.
And mailing those. So what they do is they just generate the file. They have a letter template. They send that file and the letter template to a company that does all the printing.
Okay. And they send it to them encrypted, and then that company on the other end has a third-party encryption tool that unencrypts it, and then they do the mail.
Well, the unencryption is we have a program that they send that they email to that company.
That's one of the things that we've customized for our solution.
Yeah,
okay.
That's part of the solution.
Okay.
Okay, and then there's duplicate detection rules for client and health care provider records, so that's just leveraging the functionality that's there.
Okay.
But there is some things in the interface with the warehouse to make sure that that's managed.
Right, because I guess it would look kind of silly to send the same person the letter twice.
Yeah.
They lose some credibility with that patient.
And we're also dealing with with patient information coming from multiple legacy information systems, and they don't have the same rules around what information they require, how they record the name, whatever.
Okay.
So once that consolidation, there's only so much that the data warehouse can do,
yes,
and only so much the rules can do there to merge records. So it's inevitable that you end up with multiple duplicates in CRM.
Okay.
So we leverage the rules in CRM for someone to go through and then look and say, yes, this is the same person.
Okay.
Do that merge in CRM and also force.
So it doesn't automatically do the merge. Somebody still must manually go through and choose which record survives, or if they do merge. Or,
exactly.
Okay.
But
gotcha.
using CRM to do that instead of building some sort of web app to do that through the warehouse.
Right. Right. Okay. Good.
And then it's designed to support multiple communication mediums. This is, you know what's available in CRM. It's mail, email, phone. Currently, they're only using letters.
Right.
But it's not that it can be extended.
Okay.
Okay. And then this is our interfaces or solution diagram. So on the left-hand side, we have all the clinical information systems that could feed data about the patient, right?
Okay.
So right now we show here, because this was built for the BC cancer, breast screening, cervical screening, and colon cancer screening, and then it could be any X screening program after that, or this could be any type of clinical information system, right?
Okay.
The data is all consolidated in the data warehouse where one record's created.
Okay. So this is where our CRM system is not going to those clinical information systems. We're going to the data warehouse to retrieve it, where the data has already been filtered to our subset of data.
That's right.
Okay.
Yeah.
And did we create the data warehouse piece? Did we say this?
No.
Did we create the fields and the tables? No. Okay.
The entire data warehouse was built by, and the interface with CRM
Yes.
was built by two people at PACE.
Okay, so if we were to go and drop this in Alberta then, Alberta, we would need to work with the locals, so there would be some tweaking to get them to create
We'd work
the data
with them,
warehouse.
or we have to build that.
Okay.
We have to have resources to build that piece, right?
Gotcha.
It doesn't exist today.
Gotcha.
To be honest. And so you'll see two arrows here going back and forth between the data warehouse and CRM. So there's the client and healthcare provider data that's going over to CRM.
Okay.
The reason why healthcare provider data is included is sometimes the client sent letters, and sometimes the provider sent a letter. Depends on the program. It depends on the current process of the day and how they're recruiting and recalling people.
Okay.
And then the information coming back from CRM to the warehouse is clinical eligibility rules. So we talked about how each program has what they consider to make it for a person to be eligible for screening.
Right.
So they manage defining those rules in CRM.
And then I see you have the one-way touch point going back to CRM to the data warehouse with the clinical eligibility rules. There's no then from the data warehouse pushing that clinical eligibility information back to the clinical information systems, is there?
No, so the warehouse has the data from the clinical information systems that they require to make the decision.
So the one-way pull into...
And there's a flag that's set on the record in the warehouse of whether the person's eligible or not.
Okay.
And it stays there, it doesn't go back anywhere else.
Gotcha.
Okay.
Okay.
So then within CRM is where we're managing all recruitment and recall functionality, and then the output from CRM is formatted letter files. If they're gonna print them internally and send them off, right? An encrypted recipient list, like data file that goes to a third party for distribution. There's also a process that they do, so they get information from the ministry, but it's not always current, or the patient's address isn't complete.
Right.
So they take an anonymized list of addresses. So this would be if they're going to recruit people.
Right.
They send the addresses for verification.
Okay.
So that goes. So the list is produced from CRM by the recruitment process and customizations. Goes out to the third-party address verification. There's an identifier for each address, right?
Okay.
In the file. It comes back to the warehouse. Gets loaded into the warehouse where that information gets updated, and if the address has been updated, then only the updates get sent over to CRM and everything goes off to them.
Gotcha.
Okay.